each group, from nursing to physicians to registration to EVS to transport to radiology to pharmacy to blood bank, I think my proudest moment was during that response, because it showed how an organization can respond, not a department. And that in that moment, for the first 2 hours, the event was in the ED, and that's where the focus was. But then as time moved forward, the event magnitude moved from the ED up into the perioperative areas in the ICU. And the next 24 hours, it was the med surg units. And just that evolving motion of like where the focus was, I think was probably the proudest moment, because how we responded as a team, it wasn't about the individual abilities of any one person, but it was really how as a group can we respond to a situation that just, for no other means, just sucked for all of us. It was like, no, this is our city. You don't get to do this to us. And we all responded and just stood up and just said, like, no, screw you. Like, you don't get to do this to us on our day. It's like, this is our city.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everyone, Kevin McFarland here from the Art of Emergency Nursing. Thanks for downloading this episode, and thank you as always for listening to the podcast. Don't forget to leave a rating and review if you haven't done so already. That's how other people like you are going to find this show that you like. I told you in the last episode that we're already planning the next Nurses PodCon. There's now a website where you can vote on the location for the next one. The locations being considered are, drumroll please, Nashville, Tennessee, Austin, Texas, and last but not least, Las Vegas, Nevada. Go to the Nurses PodCon website. I'll leave a link down in the show notes, and vote on the location you would be most likely to attend. We want to get you to come out and see us, your favorite podcasters. Now, on to today's show. A lot of times in the emergency department, we don't fully understand the impact of the incident, not only on the victim, but the families, and oftentimes many, many others. Sometimes we're fully aware that we are in the middle of what will be history. In this episode, I'm going to talk to a nurse who's an ER nurse, a nurse leader, and even a DMAT nurse. He's going to tell us a little bit about the time that he and his team were called to be part of history. This is a great episode that will reignite your faith in the human spirit and remind you what heroes nurses really are. You are going to love this episode with my friend, Dan.
All right, so my name is Dan Nadworny. I am currently the Director of Emergency and Patient Care Services at Milton Hospital in Milton, Massachusetts. I've been in the role now, actually I was just changed this past January. Prior, I was the Director for Emergency and Critical Care, so I took on the inpatient services and moved to Milton Hospital in October of 2018 after being at Beth Israel Deaconess Medical Center for 16 years in their emergency department. My work really has been here in Milton, has been around managing nursing services through the care continuum, from emergency department through ICU to the inpatient level of care and everything in between. Outside work, I continue to work with the Emergency Nursing Association in Massachusetts, working as the Government Affairs Chairperson for the state, and I've been in that role for the past 7 years, working with legislative activities with our ENA President and the National ENA Office, and trying to move forward nursing priorities, working with our ACEP partners and other coalitions here in the state. Outside those two roles, I work as an active member of the National Disaster Medical Services. I'm a supervisory nurse with the Trauma Critical Care team based out of Austin, and I've been part of that team, which used to be called the IMSIRT, which was the International Medical Surgical Response Team, since 2003. So I've been kind of in the world of emergency management and emergency preparedness for the majority of my nursing career overall.
So you live in Massachusetts, but you're stationed with the disaster team out of Austin, did you say?
No, out of Boston. So
Boston. Boston. I'm sorry.
Yeah,
I thought you said Austin.
Yeah, so Boston to Boston. So there's 3 teams. There's East, which is based in Boston, the West team in Seattle, and the South team out of Miami. So each team has one home hospital group that they work out of, and I'm on the East team.
Cool. Very cool. Holy cow, you keep busy, don't you?
Yeah.
Keeps you out of trouble.
Keeps me out of trouble.
That's right. How'd you get into nursing?
Coming out of high school, I really knew I wanted to do something in emergency medicine in some way or another. And I had done some shadow programs in EMT and was really tossing between whether I wanted to go into nursing or physician world of things. And I just found that nursing was more connected to like how patients worked. My dad was a pharmacist, and my aunt was a nurse practitioner, and watching how they worked with people was, I think, a big influence for me. And there was a small part of me that said, I don't really know what I want to do, and I know if I go to be the physician side of things, if I go down a path and I say like, oh, I want to be a surgeon, and I change my mind, I have to go back to residency again. If I want to be a nurse, and I want to do emergency medicine or ICU or maternity or med surge or med flight, I can change easier. And I felt that was more appropriate for what I was looking at doing. I wanted the variability of options of what I wanted to do. So that was the main thing. And, going into school for physician, you're talking 12 years before you get done with it. And little did I know that I would just take another 15 years to do the same thing, basically to get my doctorate now.
Do you have your doctorate?
I do. Yes, I got my doctorate from Simmons College in 2018.
Congratulations.
Thank you. Yeah, so I did my doctorate in nursing practice with that program.
Good for you. Good for you. What made you decide to go for your doctorate?
One of my managers, so my director at Boston, Kirsten Boyd, was one of those people who always was like, okay, where's your comfort zone? I'm going to push you 3 steps beyond it. And was always pushing me and pushing me and pushing me. I finished my master's with a cohort program at the hospital, and the hospital was offering a cohort program with a group of people, of managers at the hospital. And she's like, you need to do this. I'm like, I am not ready to do my doctorate. She's like, you're going to do this. And she just kept on pushing me. And I'm like, finally I gave in. I'm like, you know what, fine. I give in. I'll do it. And then I realized how much of a benefit it was going to be. And, having the benefit of an organization that supported nursing education. So there was 8 of us from the hospital who together took the doctorate program together, including my CNO, my associate chief nurse. And that opportunity to learn from the leaders you respect, I think, was as valuable as the coursework is associated. So I think that was a big driver for me to understand. It's when you look around to the nurse leaders you work with, you admire, and you try to emulate, those are the people, if you have an opportunity to learn with them, you just grow yourself.
Yeah, absolutely. Absolutely. It's nice when you have leaders around you that can inspire you to go further yourself, to push you outside your comfort zone and then help you get there. That's really cool.
Yeah. Not only nurse leaders, but also organizations who recognize the value of nursing leadership and the investment that's necessary to further what nurses bring to the healthcare system.
Absolutely. Absolutely. It's nice to work for an organization that's forward thinking like that. So
yeah,
that's a good thing. At what point in your career were you sure you made the right choice?
So I would say one of the moments for me was really working at our hospital was a clinical advisor. And this was a person who was one step up from the bedside resource charge nurse position. So you were kind of leadership, but you were just like one step below the manager level. Mm-hmm. And staff told me how working with me and how I was able to influence not only the care of one patient, but able to change practice and help guide practice to make things work better. I think that's when I kind of realized I actually make a difference. And it's not about making the difference in a single patient's experience. It really is more about like, how do you change the way the care is delivered to make it better for many patients? And that's why I really realized, like, this is what I'm meant to do. Like, this is how I can really benefit people. It's how do you share an idea that improves the care, like how a patient arrives by triage. And if you change the arrival pattern of triage, or you change the arrival process for patients that makes it work better for everybody, you improve the care for hundreds, not just one. I think that was one of the biggest things for me.
Yep. That's it. One of the things that I never fail to, I always appreciate how much of an impact you can have on people as a nurse. Like, it's exponential. It really is.
Yeah.
So it's kind of crazy.
And it's also the idea of guiding the next generation of nurses and sharing like what we've all learned. I think we've all been fortunate to have experience and exposure to nurses who kind of guided us and gave us tricks of the trade about things like either directly telling you this is what you should do, or sitting back to the sidelines and watching the way that a nurse manages either the challenging IV or the challenging patient, and watch like how they do that. And like when you can give that to the next generation of nursing, I think that's such a gift to be able to show the people like, here's a trick, this will work for you. Or to say to a person like, oh, by the way, we've all been there. Please don't feel like you're the first person ever to have a med error in history, because we've all been there.
Yep, absolutely. Speaking of med errors, do you remember your first?
Yes. Yeah, my first med error was working in an ED, and I walked into I was working in a behavioral health unit, and I walked into a patient room, and I'm like, hey, Mr. Jones, how are you? He's like, I'm doing good. Can you confirm your date of birth? And he said something, and it was, I'm like, oh, it was whatever he had said. I'm like, yep, that's great. That's what it was. I gave him the medications. I walk into the next room. Hey, Mr. Jones, I'm Mr. Smith. And I'm like, oh, no.
Like, oh.
And, like, the stomach just, like, dropped out of me. And I'm like, I felt nauseous. I'm like, oh, there goes my job. I'm like, I wonder if I get a job at Burger King. Like, what am I going to ever do again? Like, and it was a person who was boarding in the psych area, and I gave him an extra dose of folic acid, and instead of getting, his Abilify, I think I gave him metoprolol, and it was only 12.5 milligrams. I told the doc's like, oh, whatever. And I'm like, no, I gave him the wrong medication. He's like, yeah, I know that, but like, don't worry about it. I'm like, but I gave him the wrong medication. He's like, I get that. Don't worry about it. Just put him on the monitor, and if something bad happens, we'll figure it out. Yeah. And, this is before we had barcode scanning, and, you realize how vulnerable you are when you walk in such to a psychiatric patient and you say, like, hey, Mr. Jones, they're going to nod your head at anything. Like, I could have walked in and said, hi, are you Mark Simpson? He'd be like, yep, no problem. I don't think it would have mattered what I said. He would have nodded his head at me.
Yeah.
So that positive patient identification side of things, it is what it is. And, thankfully there was no bad outcome to it, but it definitely, one of those marks you remember. I remember what room it was in. I remember going to my resource nurse, going to my manager, and being like, I screwed up. And they're like, okay, put an event in the system. Don't do it again.
Yeah. I remember one of my first med errors as a nurse. I remember going to the director and saying, okay, write me up. Let's do this. I'm in. Yeah, this is what I did. You need to punish me now. And he's like, why would I punish you any more than you're punishing yourself right now?
Yep.
He's like, you're good, Kevin. You're okay. You're fine. Don't do it again. Yep. Don't be stupid. Pay attention. And I was like, oh, all right. And I did. So it's funny how those memories stick with you.
Yeah, it's so true.
Tell me about a patient who touched your heart.
I think, oh, geez. So I think there's two. So I lost my dad when I was 8 years old to a pulmonary embolism. And I was working as a travel nurse over at one of the hospitals outside of Boston. And actually somebody I knew, her dad came in with a PE. And he was in respiratory arrest. It was a very similar situation. I remember, like, taking care of him and also taking care of her at the same time. And just remembering like how fragile I was when that happened to me, and having to be the nurse now taking care of her father who was having this event that's taking place, and I knew exactly the outcome. So like, he was not going to survive. And I knew that early on. You know, he was already in cardiogenic shock. He was hypoxic. There was no opportunity for ECMO. There was no opportunity for lysis, really. Like, you were already there. And I just remember, like, being there and hearing not only her cries, but also remembering my own tears and my own pains of, like, losing my dad. And, like, being in that same circumstance was probably one of the harder moments. And I remember just, like, after that shift, just, like, walking away and just being like, I don't... You look at those moments of, like, how do I do this? And how do I go back? And how do I take care of a patient where I know that same thing could happen to me?
Yeah.
I think that was... Yeah, it did. And you don't know how many times you can reopen the same wounds. And there's that piece of, like, we all carry baggage with us, and each one of us, you never know where you've been before. I remember taking care of him and just knowing that I wanted to keep him comfortable and keeping her informed and not, you know, one of the things that I didn't have is I never had an opportunity to see he was there and then he was gone for my dad. And she was there the entire time and wanted to make sure it was a respectful moment for her, knowing that her dad might be dying.
Holy cow.
And how do I keep it as a therapeutic moment for her so it's not something that's terrifying?
Yeah.
And I think the other one is after the Haitian earthquake, being down in Haiti, there was a young girl there that had a horrible burn injury to her leg. And we were down there taking care of the group of people there, and every day she would come into my clinic that we were running with the disaster team. We were doing wound management. We have to do conscious sedation with her to do her dressing changes. And here's this girl who's an orphan and speaks very little English, and I speak horrible French and almost no Creole and very little Spanish, and I'm trying to communicate her with some variation of charades and mixed languages. And give her comfort.
Yeah.
And she's there in this Sunday dress, and it's this flowered pattern dress that they all wore because when the earthquake happened, a lot of them still had their Sunday dresses on.
Yeah.
And remembering her and this horrible leg injury and just connecting to her and just always wanting to hold her, and I would carry her from the holding tent where we had the kids into the procedure tent, do the sedation, and I would carry her back to the holding tent and sit with her for a period of time until she kind of came out of the anesthesia that we were using, which was basically just ketamine. And not ever knowing what happened to her, I think was probably the hardest thing for me. I knew she could walk by the end of the time we were there. But each day carrying her and just holding her was just so hard for me.
I bet. Holy cow. Peds are tough, especially when they're so injured.
I mean, that's before I was a father. I can't imagine doing it now having my kids.
Yeah. How do you think you'd handle it now?
I don't know. But, I think you face the adversaries that you have in front of you with the tools you have.
It's true. Let's talk a little bit about your time in like the disaster team. So you were down in Haiti taking care of folks. What was that like?
Haiti was really a remarkable event. So Haiti was the disaster that I'm on. We were one of the first U.S. interests on island. So the night of the earthquake, we got put on alert. That night, I remember driving home, getting a call like, "Hey, we're on alert to go down to Haiti." I'm like, "Oh, what happened in Haiti?" Like I think I'd worked a shift and hadn't even seen the news.
Yeah.
And we got down there, and we were tasked with setting up a field hospital inside a school courtyard. And we got down there in the middle of the night, put the tent up, and we woke up in the morning and the patients just started coming and just kept coming and coming and coming. And you get that idea of almost like a fog of war where you carry on with things where it's like, oh yeah, we just did that because we had to do it. But then you look back and you're like, what did we do? And we were co-located in this one area with one of the disaster medical assistance teams from Massachusetts, who we all know really well, worked a lot. And then our MCERT team, and then we had 82nd Airborne for security with us. And outside the school courtyard, there was actually a refugee camp. And for a while, we actually were the highest level of care on the island because we actually had an ICU and OR capability. So we actually had ventilators and a full OR. So we were doing surgery every single day. And it was everything from X-fixes to amputations, X-flaps, a little bit of everything.
Wow.
And, we made do with what we had. And the typical DMAT IMSR cache did not have isolettes. And I remember this is one of the things where I'm very fortunate to work with some people who just they put MacGyver to shame, where they can find ways of, the logistics guys that work for these teams and some of these people that work with us, from the Seattle Fire Departments, the Massachusetts Fire Departments who work in the DMAT teams, those logs guys were just brilliant. Hey, so we don't have an isolette, but if we take a cardboard box and we put a space blanket inside of it, and then we take IV fluid bags, we warm the IV fluid bags on the generator for 15 minutes, they get to be whatever the temperature was, and then you tuck them in there, you can put a baby inside, there's some padding, and it acts like an isolette. And we're like, okay.
All right.
Sure. We can do that.
You're like, okay.
And that's what we did. And, we were doing traction splints on patients. And okay, so we had this great orthodox from different hospitals, but they're okay, we need 10 pounds of counter traction. And we're all looking around okay, where do we get 10 pounds of counter traction from? And the schoolyard, being in an earthquake zone, had some crumbling of the walls. So we'd go over to the wall of the concrete, and we'd pick up a stone and be like, okay, what do you think this weighs? It feels like about 7.5 pounds. Close enough. And we'd take out our Boy Scout handbooks, and we'd tie a knot to it and tie it over a tripod, which we'd lash together with tape, and that's how we did counter traction.
Holy cow.
And it was just one of these events after another. But at the end of the day, what it came down to, and I think where we all had the most impact, was not around the technology that we deal with healthcare today. It was the human touch. It was the fact that we were able to connect with a child. We were holding kids. We were walking with patients. We were learning the language a little bit. By the end of it, we could all speak a little bit of French Creole to say, how are you? I am Dan. I'm a nurse. I will take care of you. How can I help you? Thank you. You're welcome. Those basic words. And I think that's what I took out of being in Haiti, was this remarkable culture of a population that, despite going through one of the worst tragedies ever, they were appreciative. And their culture of giving was as much about their resiliency of who they were as a people. And even in the middle of all this, they would come and offer us food. Now, wow. Here we are, we're the Americans, there was all these different things. They would come and they would offer us food. And it was probably the most raw moment of nursing for me, was being there and taking care of those people, because it wasn't about ECMO. It wasn't about cardiac catheterizations. It wasn't about any of the bad things, the big things we talk about, the big technology. It was purely about the basics of nursing care, the basics of medical care of, you have an illness, how can I help you? And so much of it was about your individual diagnostic capabilities. It wasn't about, I can do 3 CTs, an MRI, a PET scan, a VQ scan. It was, how good can I listen to your lungs? And what do you look like in 4 hours or 12 hours or 18 hours or 24 hours from there? So I think that was probably the most remarkable part of it. And then just watching the worldwide response was just amazing.
Yeah. But isn't that always nursing, though? I mean, you think about all the stuff we do in the ICU, all the stuff we do in the ER, and I know ERs that are doing super advanced, ECMO in the ER, all kinds of crazy stuff. the reality is, like, the patients never remember any of that stuff. All they remember is how well we treated them. It's all they matter. It's all they care about.
Mm-hmm.
And it's what families care about too. And through all that, even like in a disaster situation, you can still make that human connection enough that they're like, wow, you really cared for me. That's I think the magic of nursing. I think that's the coolest thing about nursing, is that, like, through all that, you can still do that.
No, it's true. And I think the line is that nursing is a balance between art and science.
Absolutely.
And there's the art of how you care for a person and the science of what allows you to care for that person with it. And, I think you hear about people who say they're a good nurse, but. And I'm sure we've all had those moments where you're like, oh, yeah, that guy, Dan. He's a good nurse, but, man, he can't talk to a patient. And it's one of those things where I've always challenged people, but then they're not a good nurse.
Yeah.
Because you can't tell me that you're a good nurse by technical skills. Like, oh, yeah, he can put an IV in anybody, but don't ask him to take care of a patient. Like, well... then you're a skill person. That's a challenge, I think, that for nursing, I think we face. Is like, this shouldn't be a good nurse, but you are a good nurse, and you're a good nurse. We may not always have our moments where we're the perfect nurse, because we're all going to have those moments where, like, we all have bad days. Like, I can't hit the broadside of a barn with an IV, and I'm not going to be therapeutic with the person for whatever reason.
Yep.
And having that ability to look at yourself and reflect on that and understand that, I think is so important.
Absolutely. I think, one of the things I always tell, we just got done, we're working with a group of new grads right now. And one of the things I always tell them, I was like, the IVs and all that stuff, all that practical stuff, all that skill stuff, that's really cool to know. That's, you'll pick that up. You'll pick that up whether we teach you a whole lot of that or not. But it's the critical thinking and the caring that we can't teach you. Like, you're gonna see people, you're gonna witness that, and then hopefully do that. So
yeah, you can teach anybody to do a skill.
Absolutely.
The challenge is, how do you guide them to why are you choosing that skill?
Yeah, why that skill, and then how do you treat people while you're doing that skill?
Mm-hmm.
So, absolutely, that's one of the things I was telling these new grad nurses is, it's the skills will come. Don't even worry about that. Don't forget. I always tell people, I was the very last, when I took my EMT class, I was the very last person in my class to get a live IV. Did fine on the mannequins, but just couldn't get. I think I tried 2 or 3 students before I actually got it. And finally I sat this guy down and I was like, I'm going to dig in your arm until I find something. So I just need you to hold still. And he was like, and sure enough, I did, man. I dug in his arm until I found the vein, and boom, got it. And, I was like, okay. And I was like, all right, finally got it. Finally got that one done. So, but it's the skill that people aren't going to remember that.
No.
What's the best advice a nurse mentor ever gave you?
So I think there's 2. So one is like being a nurse, and one is being a nurse leader. So I think for being a nurse, when I first started out, I was on a trauma surgical unit, and Joanne Jeffries, my nurse, my first preceptor, like, she was the one who taught me to be a nurse to start off with things. And she said, always be honest to your patients. And it was around whether I knew something. And she said, you cannot know everything. And being a new grad, her telling me it's okay to say to the patient, I don't know that answer, but let me get back to you. And I think she guided me to that point of, like, saying, it's okay to say I don't know something.
Yeah.
And I think that was probably the best advice. I've held true to say it, even as a nurse leader, and saying, like, you know what, I don't know the answer. And if it's a research question, or if I'm mentoring a person, it's like, but let's work on it together. So, like, I've been working at, like, when I've been precepting, and somebody, like, stumps me the question, like, you know what, I have no idea.
Well, let's look that
but
up.
I know let's go look that up, and let's go research together. or it becomes homework for the preceptee. One of the two.
Yeah.
So I think that's probably the best advice that's been given to me. I think as a nurse leader, was really around the idea of, my advice from my assistant chief nurse is saying, when you feel like you're comfortable, you need to move forward, and always being willing to move out of your comfort zone into something that doesn't feel real to you. I think it was probably the best advice given to me as a nurse leader, is saying it's okay to fail, but you have to try, and you can't grow without moving outside your comfort zone. And she would always push me and give me something new to do, and say, okay, I want you to build a budget for something, or I want you to model a plan for something. And she wouldn't tell me how to do it. She wouldn't tell me what not to do. But if I had questions, she'd always be there. And she would always just push me just enough. And I never felt like I was alone in a situation, but it was always like I had the freedom to do what I wanted and to experiment with an idea without feeling unsupported. So I think those are the best parts about things. Like if you're a nurse leader and you have people reporting to you, pushing them to say, okay, I'm here, but I want you to do this.
Yeah.
Is a key.
How do you know when it's time to take on the next challenge, or how do you know when it's time to move on and do something different? Like what's kind of your guidepost of, hey, maybe it's time I grow a little bit?
For me, I think when you feel like, well, let me start this way. You should always be looking to grow yourself.
Absolutely.
And if you settle on anything, I think you're already taking one step backwards. So doing something different doesn't have to mean changing your job. And I think some people feel like to do something different, you have to change your job, and you have to move positions or change departments. And that's not always the case. I think sometimes doing something different can be asking for new responsibility, even within your role.
That's a good point.
And I think the guiding principle that I have used has been, if I can look at my week's calendar or my month's calendar and say, okay, I can do every task on here without breaking a sweat, that's the time to say, I need a new challenge. So if you're on a committee and you show up to the committee and you're doing things, let's say I was on the hospital code committee and I show up and I do different things. When you get to the meeting and you sit down in your chair and you're in the back row and you pick up your phone in the meeting, now's the time to move forward, to either ask to be a co-chair for the person, or to ask for a subcommittee on that piece of work, or to ask how to improve something. As far as when to change jobs, for me, it has always been around when you don't see an immediate ability to have vertical or decisive change. I've been fortunate where several of my job changes have been out of necessity, so taking on a new role because a new service line opened up, or there was a departure of a manager that needed coverage, or there was a consolidation of a service line. And I think we've all been there in healthcare where things have changed. We're like, oh, we need to reduce by 15%, and the manager, instead of having 3 managers, now you're going to have 1 manager. And now all of a sudden you have an opportunity as a nurse leader to take on oversight of another group. And that happened to me twice, where I actually took on our registration staff for a period of time. And it was one of the most eye-opening experiences of my career, of trying to understand how registration happens and all the intricacies of that, and all the insurance changes and everything, and making my head spin.
Yeah.
But then also being able to bring nursing to them and understand, like, well, why are nurses telling you to get out of the room right now? Like, registration's like, all I need is a date of birth. I'm like, I get that, but they're not going to tell you a date of birth that makes sense because they're delusional. So there's always opportunities there.
Yeah. What advice would you give a brand new nurse going into the emergency department?
So I think being a brand new nurse in ED, I think the biggest part is to be a sponge and just to look around of like what's around you. And it's okay to ask questions about why do you do that? Because as a new grad nurse, you're probably the closest to, the recent knowledge for a lot of us. As much as we'd like to think that every single nurse was reading the Journal of Emergency Nursing every single week, we're not.
Yeah.
And that's unfortunate, but I think that's reality. And there are nurses and nurse leaders and organizations that have practices that are in place just because it's the way it's always been. And when you bring people into an organization, especially when they're the first ones in or their first experiences, they look at it with a new perspective and a new lens. And when they look at how you do something, they may ask and try to understand, well, why do you do that? So they're good questions to ask. There's no reason to ask, like, why not to do that?
Yeah.
The other part of it is, I think, don't be afraid to make a mistake. No one knows everything.
How do you balance that? Don't be afraid to make a mistake, but yet be cautious enough to. Oftentimes, new grads don't know what they don't know. How do you balance that point of, don't do something that's going to hurt somebody. You don't want to make a grave mistake. You don't want to make a big mistake. You're fine with them making little mistakes, but it's okay if they step in it once in a while.
Well, I think it comes back to like understanding what your scope is. So, as hospitals have moved to the idea of high reliable organizations, we've tried to take away the systematic errors that are in place and the risks. So as the new grad nurse coming in, if you follow the process in the typical practice, let's look at barcode scanning, for example. It's okay to make a mistake because you got in the bedroom and you open the drawers of the Pyxis or Omnicell, whatever you use, and it said grab pocket 1 and you grab pocket 2. And you pick up the medication and then you look at it and you're like, oh, I want to give metoprolol. I have Cardizem in my hand. That's a mistake.
Yep.
It's okay because you didn't get all the way to the patient. But don't be afraid to tell your preceptor I grabbed the wrong pocket. Because that's a minor mistake. When you get through multiple safety barriers and you break them all, so if you you open the Pyxis, you grab the wrong pocket, you walk in the room, you don't talk to the patient, whatever you have in your hand, you pull it up, you draw it, you give it, and you never barcode scan it, and then 2 hours later you go back and you document the medication, that's being, I think, to some level, it's almost irresponsible. And that's the balance. You can have a small error where, I should have given this with a 19-gauge needle, I gave it with a 22-gauge needle. Or those lung sounds are wheezes. No, they're actually bronchi. Those things, I think, where you are allowed to make a mistake on those things. Missing 6 IVs. Not able to place a Foley for the first 7 months of your career. Those are mistakes that are inevitable and not to be ashamed or afraid of saying that that's a challenge for you. Or the fact that you cannot hear a heart murmur.
Yeah.
Where you can't make mistakes is when there's a set policy of you shall do it this way. And if the hospital policy is, and for all of us, it's always the 5 rights. These are things we teach basic to nursing school. These are not things that are independent of my hospital, your hospital, anybody else's hospital. It's the 5 rights of med administration. You've got to do that right. So those are things where you have to do that right as a new grad. And if you don't know the medication you're giving, or the side effects, or the contraindications, or the interactions of the medications, you've got to ask. And it's a big challenge for new grad nurses going to emergency medicine. One of the apprehensions I've always had is your first medication you give away from nursing school should not be epinephrine. It should be Coles.
Right. Yeah, you're right.
If I triple your dose of Coles, you might have the runs. If I triple your dose of Epi, we got a bigger problem. And I think that's the hard thing of emergency medicine. A lot of medications we give, when they're not giving either by the appropriate dose, the appropriate route, or the appropriate timing, have consequence, which is very different than med-surg nursing, where you're giving the patients their medications they take at home, because they might take it 5 o'clock in the morning one day, 10 o'clock in the morning the next day, and forget the next 2 days.
Yeah.
So the medications of consequence are more impactful.
Absolutely. Tell me about a patient who made you laugh that you'll never forget.
So we had a urban outdoorsman, is what they call him in Boston sometimes. And he was this very petite little guy. And when I say petite, he was maybe 5'2" and maybe 80 pounds soaking wet. And it's unfortunate because of a circumstance where he was just a chronic alcoholic. And he more than likely had a significant encephalopathy because of an alcoholism. And most days he was happy. And most days he liked being in the hospital with us. And he loved music and fashion. And we would have a closet of clothes. Our homeless population that was donated from different people that we would give out. And he would like to ask for certain types of clothing. And he would ask for the leopard prints. He would ask for leather pants. He would ask for all these different things. And so the first question I would ask was, who's donating this stuff that has leather pants from our staff? And the next question is, who thought a homeless person would be walking around Boston in leather pants? But that was him. And he would just, he would come in the night, he would be heavily intoxicated. And again, it's an unfortunate part of who we are as a society, but that's who he was. And that's how he lived. And he would have his moments of not being very nice and swearing at the staff. In the morning, almost always, he would just be like, I gotta go now. And more mornings than not, on his way out, he'd be blowing kisses to the staff and saying, I love you all, as he walked out in his way. But he just always made me laugh. And just like, oh, there he goes again. And I'd see him around town from time to time. He was always laugh.
That's funny. It's funny how we get to know those regulars so well.
Yeah. It's bad when you see him at the bar, and you're like, oh, hey, how's it going? Like, you know him? I'm like, kind of.
We were one time we had a guy who a patient I'll never forget, and he was huge. He was a big dude. He was probably 6 foot something. He probably weighed 300 pounds. He had muscle. Like he was a big muscular guy. He looked like a professional wrestler. And he kept saying, he's like he was behavioral. Was what he was there for. He was an alcoholic, and he was a mean alcoholic. And he kept saying, I'm gonna go off. And we were like, don't go off, so and so. Don't do that. So finally, out of nowhere, we had this other patient there who's causing a commotion, and next thing you know, he like gets up and is like, kind of does the Hulk, I'm gonna smash everything. And me and this other guy like tackled him, and we had to tackle him and bring him down to the ground. The whole time, his father, who worked at the hospital, was watching, and I was just like, oh my god, this is terrible. So sure enough, we get him taken care of, and we as soon as he kind of hit the ground, and he was like, oh yeah, it's good. He blew his steam, reminded us that he was really gonna do it, and then he was just fine, right? So he got a little bit better as soon as he kind of hit the ground and realized that we were gonna restrain him. We ended up restraining him, and sure enough, he was fine. A couple hours later, he was fine. Ended up going home. So about a week later, I run into this guy at a restaurant. Like, I see this guy, and he was there all the time. He was there frequently. Like, we knew him well. And I'm there with my nephew, and I see this guy, and I'm sitting there going, oh, Jesus, that's so-and-so. And he looks at me, and he's all, hey, Kevin, how you doing, buddy? And I'm like, oh, God, here we go. And he was there with a young lady, and he goes, this is Kevin. He works with my dad. And I was like, oh, yeah. I go, how you doing? He's like, I'm doing great, man. He goes, I'm doing a lot better than last time you see me. And I was like, oh, okay, that's good. He's like, I'm really sorry for, sometimes I can be kind of a jerk to take care of. And, I appreciate you. And I'm like, thanks. And I was like, okay, well, see you later. We'll take care. So they're going, oh, that was awkward. And he was like, just as pleasant as he could be. And I was like, oh my gosh, that's just weird. So, and my nephew's like, that guy? I was like, yeah, we kind of tackled that guy just the other day. So,
well, emergency medicine is a reflection of our communities, in some ways more obvious than others.
Yeah, for sure. So I definitely think that's true. So tell me about your best memory of being an ER nurse.
Oof. I think my best memory of being an ER nurse, unfortunately, was around the marathon bombings. And it wasn't about one specific event, but rather how the ED responded in the entirety of it all.
So tell us about that. Was your ED close to the site?
Yeah. So at the time I was working at Bethesda Deaconess in Boston, and every year we stood up a marathon clinic within the ED because we were right along the marathon route. And between the years, we'd see anywhere between 20 and 60 runners from the marathon. And it's everything from hypothermia to rhabdo to everything under the sun. And the year of the bombing, it was perfect weather, and we actually were hoping for not having a lot of problems because the year before it had been, the year was almost 80 degrees, and we had all the hyperthermia cases. So we were doing ice baths the year before, and when the bombing started, the first blast occurred, we kind of like all of a sudden all went to disaster mode, and not having the full information, we started responding and just like ramping up and ramping up and ramping up and ramping up. And each group, from nursing to physicians to registration to EVS to transport to radiology to pharmacy to blood bank, I think my proudest moment was during that response because it showed how an organization can respond, not a department. And that in that moment, for the first 2 hours, the event was in the ED, and that's where the focus was. But then as time moved forward, the event magnitude moved from the ED up into the perioperative areas in the ICU. And the next 24 hours, it was the med surg units. And just that evolving motion of like where the focus was, I think was probably the proudest moment, because how we responded as a team, it wasn't about the individual abilities of any one person, but it was really how as a group can we respond to a situation that just, for no other means, just sucked for all of us. It was like, no, this is our city, you don't get to do this to us. And we all responded and just stood up and just said, like, no, screw you, like, you don't get to do this to us in our day. It's like, this is our city.
There was a huge community rally when that happened. I remember seeing on the news, and certainly I wasn't there, but it sure looked like the community really came together.
Yeah, I think the outpouring from the community, I think we're actually seeing it now with some of the COVID world, is the recognition of the work of healthcare providers is not understated or not to say it's understated, but I think the general population understands the work that we do every single day, and they recognize the sacrifices that we make. And when you have these moments take place, and whether it's the Boston Marathon bombing, Hurricane Katrina, the Haitian earthquake, or COVID-19, people recognize the work and the training and the expertise that we do in emergency medicine and across the healthcare spectrum. And I think they applaud us for that. They applaud us for that. And I think it's touching to see. It's touching to have an exposure to it, which we don't always have. I think, unfortunately, too many days go by where people leave the ER. We're so focused on the negative patient satisfaction scores, and we don't always hear the thank yous that are deserved. It's unfortunate we have to wait for a pandemic or a tragedy like 9/11 or the marathon bombings for people to recognize the role that emergency providers play, whether they're hospital-based or pre-hospital-based or post-acute care. We all play a part in it.
Yep, absolutely. Absolutely. One of the last questions I like to ask all my guests is a question called 3 things. I'm going to ask you 3 quick things an ER nurse should always remember, and 3 quick things an ER nurse should just go ahead and forget.
So 3 quick things ER nurse should remember. Okay, so 1, everybody's dying until proven otherwise. So never assume somebody's perfectly fine until they prove to you that they're not. There's no sense in putting a 20 gauge in if you can put an 18 gauge in until you've been there long enough to know the difference.
Huh?
No one's allergic to oxygen.
That's a good point.
Things you should forget. I think in some ways you should forget that just because you're a nurse removes you from the ability to do the work of a technician. And that every patient and every call-out is yours, and you're not below any task in the emergency department, whether that's cleaning a stretcher, emptying a bedpan, answering a call-out, or picking up a piece of trash.
Amen. Now,
I would say,
no, go ahead.
Something else to forget. Oh boy, to forget things are harder.
They are.
Able to forget some more.
How do you demonstrate that as a nurse leader? As leader, are you still willing to put on the scrubs and go in there and get work done if you need to get work done?
Oh, absolutely. On a regular basis. I'm up on either in the ED or on the floors, answering call-outs, getting people out of bed. You have to. And I think the unfortunate part with nursing leadership in general, which is different in positions, is the farther you are in the nursing leadership world. I think sometimes the farther removed from the bedside you are, physicians still work clinically on a regular basis. And I think as nurse leaders, we have an ability to make your own decisions of are you a clinical leader or are you an administrative leader. And every hospital is going to be different. You may get to that point where you have enough clinical leaders below you to need to be on the administrative side of things. For my hospital, I'm not there. So I think there's not enough levels between the clinical leader and the administrative leader that I need to be at the bedside. I need to understand how things are working to feel confident that they're working the way I want them to be, and that there aren't barriers and roadblocks in place that I don't recognize. Other things to forget. Geez, I'm trying to think of this one.
It's a hard one.
I would forget that anybody's an IV expert all the time, because it's not true.
Absolutely.
You're going to miss them from time to time, and even the best person in your department will be. And I would forget that any patient actually read the book about the typical presentation. So
you mean they don't always come in with the typical presentation?
Yeah, so I think the idea of typical presentation should be put aside with the idea of magic 8 balls and crystal balls, because the typical presentation, the last time I saw a typical presentation of an MI, yeah, it's been a while.
Yep. I think there are some things that do come in and looking like the typical presentation, but there's a lot that don't.
Yeah.
And
I think that's part of that is like no one ever told a patient you only can have one thing wrong with you at the same time. So every book always talks about the presentation of one symptom or one diagnosis type. And we always talk about the fractures, like, okay, how do you splint a person with a tibial plateau fracture? It's like, oh, you do this. Well, what do you do if they have a tibial plateau fracture and a distal femur fracture?
Yeah, that's a little more challenging.
Oh, right. So when patients decide to have more than one thing wrong with them at the same time, the books don't always talk about that.
Yeah, absolutely. Well, again, Dan, I thank you for spending the time to talk to me. I really appreciate it, and the audience really appreciates it. And I look forward to seeing you and hanging out with you again.
Talk to you soon.
Take care, man. I'll see you later.
Take care. Bye.
Bye.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.